Look at this heavy stone wheel grinding away. If you run a pain management clinic, this is exactly what your daily operation feels like. A constant, exhausting friction where you are fighting on two fronts, treating patients while simultaneously chasing payments. The source of that friction comes down to a single, brutal statistical anomaly. 94% of your procedures require prior authorization before a patient even walks in the door. You won't see that rate in general medicine. It is the absolute highest authorization hurdle of any specialty in the entire healthcare system. Operationally, your doctors and staff are spending an average of 13 hours every single week, doing nothing but managing the paperwork to clear patients for care. The burden has grown so heavy that 40% of practices have been forced to hire a full-time employee whose entire job is asking commercial payers and Medicare for permission to treat people. This forces a complete shift in your operational model. You can no longer function as a purely clinical environment. You are forced to operate as an administrative defense hub just to keep the lights on. And the fight doesn't end when the treatment is pre-approved and delivered. That is just when the secondary point of failure begins, the claim denial process. Across the wider healthcare landscape, the initial claim denial rate recently climbed to roughly 12%. This side-by-side comparison highlights the disparity. On the left, you see that 11.8% overall industry average, but when pain management clinics rely on non-specialized billers, that denial rate shoots up to 25%. If we break down that massive right column, nearly 30% of those denials stem directly from self-inflicted coding errors, things like missing modifiers on complex CPT codes for epidurals. Put a price tag on that error rate, and a standard practice is writing off about $250,000 a year in unrecovered revenue due to these failures. In a specialty this heavily scrutinized, employing generalist billing staff guarantees massive revenue leaks over minor coding discrepancies. It turns an ordinary staffing choice into a severe financial liability. The traditional reaction to this revenue leak is to try and patch it internally, attempting to hire more or better in-house billing staff. But the reality of healthcare human resources tells a different story. Business operations support staff face an annual turnover rate of 33.3%. The immediate operational consequences of a biller quitting are severe. Your days in accounts receivable climb, follow-up on unpaid claims stalls entirely, and a massive backlog builds in a matter of days. Then you have the hidden costs of replacing them. You lose weeks of institutional knowledge and face a high risk of claim errors during the new hire's ramp-up period. The salary itself is also an illusion. The Bureau of Labor Statistics notes a median base salary of about $46,000 for a biller, but that number is deeply misleading. Let's look at this waterfall chart to see the true math. You start with the base salary, but then factor in payroll taxes, benefits, software licenses, and ongoing training. The fully loaded cost of a single in-house biller climbs to between $60,000 and $140,000 a year. Building an in-house billing department means taking on expensive, high-risk fixed overhead for a team that is statistically likely to leave within a year. So how do the highest performing, financially stable pain management groups stop the bleeding? AMA and MGMA data reveal specific data-driven operational tactics they use to survive. First, they move prior authorizations from a reactive billing task to a proactive workflow, integrating it directly into patient scheduling, so authorization follows the request. Second, they rethink their talent. High performers invest exclusively in specialty-specific billing knowledge, moving completely away from general medical coders who do not understand complex pain codes. Third, they enforce a strict quality control cadence. They run daily audits to catch errors on day one, avoiding the heavy cost of standard 45-day claim reviews. Fourth, they aggressively track denial patterns. When multiple denials hit for the same procedure, they fix the systemic documentation issues at the clinical level, rather than just blindly appealing individual claims. And fifth, they rely on real-time data visibility. They use weekly KPI dashboards to monitor throughput, accuracy, and collection ratios, catching issues proactively. Escaping the revenue trap requires a practice to abandon physical, localized staff management and adopt strict, data-driven, systematic workflows. This is where outsourcing revenue cycle management to dedicated, credentialed specialty firms like Staffingly offers a modern infrastructure solution. Looking at this diagram, the operational advantage is clear. Staffingly deploys AAPC and AHEMA credentialed specialists who securely connect and work directly inside your practice's existing EMR database. That model has broad compatibility, integrating seamlessly with over 40 platforms, including Epic, Athena, eClinicalWorks, and NextGen. The technology they bring with them is also highly specific. Staffingly uses AI-augmented smart routing to direct complex claims to the most qualified reviewers automatically. They also deploy automated daily AI audits to flag inconsistencies, preventing errors before the claims are ever submitted to the payer. Combining those specialty human credentials with AI automation creates a highly scalable infrastructure that mathematically drives error rates below 1%. For practice leaders, the decision ultimately comes down to a harsh financial comparison: the cost of localized overhead versus scalable outsourced infrastructure. This visual lays out the direct comparison. You are weighing the massive, volatile burden of an internal hire, costing up to $140,000 annually, against a flat, stable rate of $399 per week for a dedicated Staffingly seat. And the inherent fear of losing control over patient data is mitigated by strict infrastructure compliance. Staffingly operates under SOC 2 Type 2, ISO 27001, HIPAA, and HIT-RUST certifications. The transition protocol is practically friction-free. Interested clinics go live in just 14 days, utilizing a risk-free pilot with absolutely zero long-term contracts. CFOs and practice owners retain complete visibility, receiving structured weekly KPI dashboards managed by a single dedicated relationship coordinator. If your practice is bleeding revenue to prior authorizations and generalist coding errors, the mathematically sound decision is clear. It is time to trade the illusion of local physical control for the guaranteed efficiency and scale of outsourced specialty infrastructure.